Welcome back. Now this is the second part of the abdomen, the incisions, what we were discussing. So let's start with part 2b. Now in this part 2b, again the same slide, that table, we are going to discuss the incisions under this ellipse like grid iron or McBurney's incision, the lens or Rocky Davis, the Millard or Mackenrod, then Gibson, the Inguinal, the Venesteen or Kerpubic, and then Machivity. Right? These are the important incisions we are going to discuss in this video. So without wasting time, just let's move ahead. Again, you know that. So, okay, then grid iron or McBurney's incision. This grid iron or McBurney's incision, this is basically an oblique incision, right? Vertical, horizontal, oblique incision. You remember that? Yes. So this is an oblique incision, grid iron or McBurney's incision. This is commonly used for open appendicectomy, although nowadays laparoscopic appendicectomy is very common, so rarely used. But yes, this can be used wherever this manual access surgery facility is not available, or sometimes there is technical difficulty while using in any patient. So this grid iron or McBurney's incision can be used for appendicectomy, open appendicectomy. Basically, this is a muscle splitting incision. This term is important. Muscle splitting incision, right? We are not going to cut the muscle fibers, right? In McBurney's incision. And the level and the length of incision, the grid iron or McBurney's, it depends upon the abdominal wall thickness as well as where we are suspecting the position of the appendix. Accordingly, we will place that incision, this grid iron, right? So abdominal wall thickness and suspected position of the appendix, where we are expecting, okay, appendix probably here. In cases of let's say higher up appendix in a pulled up cecum, in patients who have recovered from abdominal tuberculosis, the appendix may be lying somewhat higher, even sometimes in subhepatic area. So accordingly, we'll use the incision, right? And it gives very good exposure for performing open appendicectomies. This grid iron incision made obliquely, told you at the McBurney point, and this McBurney's point, yes, it is the junction, lateral 1/3 and medial 2/3 over the line joining the ASIS and the umbilicus. Dissection up to the external oblique, the internal oblique, transversalis fascia and peritoneum. And in this incision, superficial epigastric and perforating branches of inferior epigastric, they may be interrupted while placing this grid iron incision. Another modification of this grid iron incision is Rutherford-Morrison incision. Whenever we are extending it, this McBurney's incision, whenever we are extending it laterally and we are converting this as muscle cutting incision, this grid iron was muscle splitting, and this Rutherford-Morrison is muscle cutting incision. Here you can see we have just extended this as compared to the grid iron one. Here you can see smaller one, this, and here you can see we have extended this and we have cut the muscles also. So it's a muscle cutting incision, Rutherford-Morrison incision. And various indications of this incision could be the cecostomy, then sigmoid colostomy, and sometimes yes, right and left sided colonic resection. In case you have already placed this incision instead of midline, then yes, through this incision also, if required, you can go for right and left sided colonic resection sometimes. Then after this, there is another incision that is known as Lange or Rocky Davis incision. This Lange or Rocky Davis incision is a horizontal incision. Here you can see an oblique incision we have discussed, gridiron. This is horizontal incision, Rocky Davis. It's basically a McBurney's modification at the same point, means McBurney's point. This incision also passed through McBurney's point. The basic difference is it is in the transverse plane. This is in the transverse plane, right? Another advantage of this Lange incision or Rocky Davis incision over gridiron is it is cosmetically the better. The outcome is good as compared to the gridiron. As already told you, similar to a gridiron incision and useful for open appendectomies. McBurney's point, again, the anatomy and the blood supply. The Lange incision is a horizontal incision, while the gridiron incision is an oblique on an oblique angle. It's an oblique incision. After this Lange incision or Rocky Davis incision, another incision is Millard. This Millard incision is also known as Mackenrod incision. And these are the important thing. Here you can see this is umbilicus, right? And this is somewhat the Millard incision looks like. In this incision, basically we are just incising the lower abdominal wall about an average length of 5 to 6 centimeter superior to the pubic symphysis. The range is between 3 to 8 centimeter, and the length of this incision should be between 16 to 20 centimeter maximum. The important thing is in this incision we are going to cut the rectus muscle as well as the deep branches of inferior epigastric. These are ligated. And indicated in cases of pathological condition where there is pathology at the upper abdomen, means the upper part of the pelvis, and the lateral pelvic wall sometimes, along with this center of the pelvis if it is involved. So means extensive disease is there, even then you can use this Millard incision. Remember, there are two incisions, Venesteen incision, you already know that, and this one is Millard incision. So these two incisions are different and they are having so many different differentiating features. For example, here the rectus is being cut. In Venesteen, rectus is spared. Here deep branches in epigastric ligated in Millard. In Venesteen, it is preserved. In Millard incision, it is meant for extensive disease. Even the lateral pelvic wall is involved, you can go with it, right? Like here you can see if the patient is having multi-fetal gestation, or if there is fetal macrosomia, or whenever there is emergent cesarean section is required, this Millard incision should be preferred instead of Venesteen. And through this Millard incision, the hysterectomy can be done even for large myomatous uterus. A scar position 3 to 8 centimeters superior to pubic symphysis, and scar length is around 17 to 19 centimeters. I have already told you. So in just to summarize it, Millard versus Venesteen. Millard is for larger exposure, larger disease process, right? Whereas this Venesteen incision is for a smaller localized disease. Why? Because there is less exposure as compared to Millard incision. In Millard incision, rectus is cut, epigastric inferior ligated. In Venesteen, rectus is spared and that is preserved, the epigastric inferior, right? So these are the differentiating point between Millard and Venesteen incision. This Millard or Mackenrod incision is a transverse incision, 6 centimeter or roughly 5 to 6 centimeter above this pubic tubercle, and it is made through the rectus abdominis, means we are going to cut the rectus muscle, right? And in this, inferior epigastric and superficial epigastric both will be damaged. This is important. So more damaging incision, Millard as compared to Venesteen. Again, I'm just putting this Venesteen just after this Millard. The purpose is we have just discussed the various differentiating point. Here you can see this is Venesteen, slightly lower as compared to Millard. This is Venesteen and this was Millard, right? Venesteen, a smiling incision, this Venesteen. Again, here you can see the rectus is retracted and saved, deep branches preserved. Pathology that is limited to center of the pelvis only can be taken care of through this incision, and only uncomplicated pregnancy requiring cesarean section delivery, then this Venesteen incision is used, right? Hysterectomy is possible for normal size uterus only, not for oversized uterus, and a scar position is around 2 to 3 centimeters superior to pubic symphysis, right? Okay, and here the scar length is 10 to 14 centimeter, means both the things are lesser as compared to that Millard incision. Clear? So always there could be a comparison between Venesteen incision and Millard. Just take care of this. In Venesteen is a transverse lower abdominal incision superior to the pubic ridge. Dissection is made through the skin and subcutaneous fat. Anterior rectus sheath is divided transversely, whereas rectus muscle is open vertically in the midline, sparing the muscle fibers. So muscle fibers don't divide in Venesteen. Then peritoneum is then entered through a vertical incision, and this Venesteen incision is frequently used for urologic, orthopedic, pelvic and cesarean sections. Drawback. Now, drawback of this incision, this Venesteen, is there is limited exposure beyond the pelvis, right? And while placing this Venesteen incision, please keep in mind the blood supply, that is inferior epigastric branches and the superficial epigastric, clear, Venesteen incision, and the deep branches, that is epigastric, that is also preserved in Venesteen. After that comes the Gibson incision. Now this Gibson incision, this can be given either side, but conventionally Gibson incision was on the left side. Here you can see it's on the left side, just above the inguinal ligament, and this is basically, it starts about 2 to 3 centimeter medial to the ASIS. This is ASIS, and it runs parallel to the inguinal ligament. This is inguinal ligament and this is the incision, right? And this incision is used for ureterolithotomy, the distal part, the lower part of the ureter. If there is a stone during open procedure, this can be used, or sometimes it can also be used for renal transplant, during renal transplant, this Gibson incision, right? 3 centimeters above and parallel to inguinal ligament is Gibson incision, used in gynecological procedures and urological procedures. And after Gibson, this again, this sometimes this Gibson incision is also used for hand assisted laparoscopy. The hand assisted laparoscopy, this Gibson incision can be utilized, right? So next comes the inguinal incision, the groin incision. This is also known as, this is inguinal or groin incision, somewhat more nearer to this pubic tubercle, and it is used for inguinal hernia. You all are well aware of this type of incision, and even in cases of testicular malignancy, this can be used in the management of varicocele and cryptorchidal, right? This inguinal incision can be used. And it is basically a transverse or sometimes oblique incision over the inguinal canal, and it is used for open inguinal hernia repairs made through the skin to the subcutaneous fat and through the camper fascia, the superficial one, and followed by deep fascia, the Scarpa's fascia. We are going through these fascia. Then superficial epigastric veins, sometimes, most of the PGs must be knowing this, superficial epigastric veins, these are commonly encountered and they must be ligated during placing the incision and going deep. The incision reaches the external oblique aponeurosis and provides access to the inguinal canal, right? And this is probably, I think, the last in this video, Machivity incision. Machivity incision is basically, here you can see this is inguinal ligament left side, and this is the direction of this Machivity incision. And this Machivity incision is used for high approach for femoral hernia repair. What is high approach? We'll see. So Machivity is a vertical incision, first of all, and it extends from the femoral canal and it brought superior to the inguinal ligament, above the inguinal ligament. We start from the femoral canal and then we are coming towards the inguinal ligament and above it, right? And it opens the femoral space to allow access to the femoral canal as well as the peritoneum. And by using this Machivity incision, this femoral hernias may be reduced and repaired either by using mesh or sutures. And even for assessment of peritoneal cavity, sometimes it may be helpful, but it provides very minimal access. And due to the location on top of the femoral canal, we must take special care not to injure the femoral vein, artery, or nerve while placing this Machivity incision. This high approach, we have just mentioned it, the Machivity, there are basically three classical approach for femoral hernia repair or management. One is high approach, second one is inguinal approach, third one is low approach. In high approach, this is known as Machivity, and basically we approach the hernial sac above the inguinal ligament, above this inguinal canal through that route, right? In inguinal approach, through the inguinal canal we are approaching that sac, and this is known as Lothesen approach. And in the low approach, also known as Lockwood approach, we approach that sac, femoral hernia below the inguinal ligament, right? So high, inguinal and low. High approach, inguinal approach, low approach for femoral hernia, and high one is known as Machivity approach, right? Here we are going to use this Machivity incision in femoral hernia. So that is all for this video. The next video we'll discuss the various incisions given over the thoracic area. So thank you. See you there. Bye bye.